Lesedi, originally called Lesedi Clinic, was built in 1985. So as clinics, we decided that it's important to change the facility as time has gone by. We've invested quite a bit of financial capital into improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labor ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. These facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labor ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. For women who'd like, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they're working perfectly.
Good evening, colleagues, and welcome to our weekly Clinics Health Group webinars once more. And we thank you for joining us tonight as we strive to bring these webinars to you every week. As we've been doing this for the last 2 years since the beginning of the COVID pandemic, the lockdown, when we started, and knowing that most of us as healthcare practitioners, all of us, we were in the hospitals, but quite a number of you were not able to have physical meetings. And as Clinics Health Group, we started with these webinars initially with our IQ Health group. And now we are glad that you kept pace with us and you've been coming in large numbers to these webinars. And so we just want to say thank you for making time to join us this evening once more. And we wish to welcome those who have not been part of this webinars. If there's anyone who has not been joining us this webinars, we trust that you will feel educated and informed as we have a session with our speaker this evening. And as usual, we request that when you log in, you please do switch off your audio and also switch off your video, so that we enhance the reception and the quality of the audio that we'll be getting and the pictures that we get from the presentations. Please also note that these webinars are CPD accredited, and we request that you make sure that when you do register, you provide all your full details, and that we will take that information and apply for CPD points, and then we will get you won't get a certificate necessarily from us, but your CPD points will be automatically uploaded with the HPCSA. And those who are not with the HPCSA, like our colleagues from the Nursing Council, you can submit and then you will get a certificate. Plus, do let us know if there are challenges with these applications. And also note that these webinars are also streamed live on on YouTube. And so they're being recorded. At the end of the presentations, we will then be sending you the link to our YouTube link. Please do like us on YouTube so that when you, on every day, you will get a reminder about this webinars, and also you can get the presentation sent to you on YouTube. And so this evening, we are excited to have one of our esteemed academics and clinicians in our country. We have Professor Zach Koto, who's a chief specialist and head of Department of Surgery at the Professor Koto Health Sciences University, and also head of department in the same discipline division of surgery, Dr. George Mukari Academic Hospital. And he's also the head of the laparoscopic and visceral surgery unit in the bariatric surgery. Last week, Prof. Koto, we were excited when we had Professor Shisana Baloy and indicated that he did some studies and with one of the surgeons from your unit, and saying that this is the first accredited bariatric unit in the country. And we just want to say congratulations on one of your many achievements and accolades that you've made in your strides as a surgeon. Professor Koto is a pioneer in laparoscopic surgery, as I indicated, in the management of trauma of patients in South Africa. And he graduated with a doctoral degree in surgery from the University of KwaZulu-Natal. He also holds an MSHB from then Medusa, which is now the SMU. And he's got a fellowship from the College of Surgeons, South Africa, and also a fellowship from the American College of Surgeons. He's renowned for performing the first laparoscopic aortobiofemoral bypass graft in South Africa in 2012. His doctoral studies showed no missed injury in penetrating abdominal trauma during laparoscopic surgery. And we had him sometime last year taking us through how he does this laparoscopic surgery. His passion for teaching and developing laparoscopic surgery in South Africa sets him apart from the rest. Not only does Prof. Koto encourage laparoscopic proficiency in registered training, he also hosts regular laparoscopic workshops for all those who are willing to learn the skill. And he hosts an annual tricks of the trade in minimal access surgery to share his experience and knowledge. And that's why we've invited him tonight to come and share his knowledge. He's taking a very different approach this evening as we're going to the ethics. He's going to be speaking to us on informed consent. And it's a pleasure indeed once more to welcome you, Prof. Koto, to our clinic's weekly webinars. And we are looking forward to gaining from your insights once more at this platform. Thank you.
Yeah, thank you very much, Dr. Bila, for that kind introduction. I don't know, am I audible? Can everybody hear me?
Yeah, we can hear you very well,
yeah.
loud and clear.
Yeah. Thank you very much for that kind introduction. Indeed, it's a great honor and privilege, I think, for me to be accorded, the honor of the podium, really to discuss a very important topic, which is really around informed consent. And I'm sure towards the end of the talk, it will enlist a lot of response, and we're looking forward to an interactive discussions at the end of my talk today. So let me first share my screen. Right, is my screen visible? Can everybody see my screen?
We can see your screen, Prof.
Okay, thank you very much. Yeah, as Dr. Villa has indicated, today I'm going to talk to you about informed consent. And again, not informed consent in isolation, but informed consent in the environment of patient-centered care model. Because I think today, we, gone are those days where, the doctor, was basically the authority, would give instructions to patients and chart the way things are going to be done, and patient would follow passively. I think today there's really a clarion call, really to look at the issue of patient participation, patient autonomy, and hence the patient-centered care. model. And so today, what I'm going to do is to unpack what I'm going to do today, try to do today is to unpack informed consent in that context, the context of a patient-centered care model. So just maybe briefly on the agenda that I'm going to discuss today, briefly I'll just maybe give a preamble on the introduction and then attempt to define what I consider as patient-centered care model. And then maybe dwell a little bit much on the elements of informed consent. And then I will then discuss 2 clinical scenarios, where a patient is going to be offered an operation and how one, goes about taking what we call an informed consent. Now, there was a committee run about the early 2000s in the US, the Institute of Medicine Quality Healthcare American project, where the committee was put together basically to look at, what needs to be done to improve health outcomes in the US. And I believe that, this initiative is not only applicable in American context, but also applicable in our own country and many countries indeed. Basically, this Institute of Medical Medicines makes an urgent call for fundamental change to close the quality gap, to improve patient outcomes. So they put together a book, basically that recommends a sweeping redesign of the American healthcare system. And as I said, this is the American healthcare system, but it is very, very much applicable in the South African context. And this committee or these recommendations provides an overarching principles for specific direction, for policymakers, people who make policies, for healthcare leaders like we have in clinics, for clinicians like myself, health regulators, the Health Professional Council, and those that purchase, healthcare. Now, basically, they put a set of performance expectations for the 21st century healthcare system. And they put together a set of 10 new rules to guide, patient-clinician relationship. And suggested organizing a framework to better align the incentive inherent in payment and accountability with improvement in quality. And the key steps to promote evidence-based practice and strengthen clinical information system. So just that the relevance of this committee's recommendation basically really centers around effective patient clinical communication, clinician communication around the issue of informed consent. Now, when you see a patient initially, the initial patient clinician encounter, this becomes crucial in the pre-op patient surgeon decision making, especially if you're going to offer a patient a high-risk surgery where there are potential serious complications that in some instances may end up or result in mortality. So in the field of surgery, informed consent has been really central. People will argue that, is a relatively recent concept, but certainly there's been, discussion around Hippocrates many centuries ago around informed consent. Certainly has been better refined recently. Now, informed consent, is it adequate for decision making? And we know that, in some instances, it can be unidirectional, where the doctor basically tells the patient what's going to happen, the patient, the risk, benefits, alternatives, but the patient has very little, participation. Am I still audible? Am I still audible?
Yeah, no, that's fine. Continue.
Okay.
Just an interruption.
All right, yeah. So again, there's very little patient participation. Now, the patient right to autonomy should always be respected. And steps should be taken to make consent truly informed. When you talk about informed consent, it should be truly informed. And I think I'll elaborate on that, as I progress in my talk. Now, if you look at the literature, many authors describe consent as a principle relatively new to medicine. As I said, it's not new. Plato, Hippocrates, many centuries ago, used consent in their medical practice. We can argue that, maybe the refinement, of informed consent certainly has become better in recent years. Now, just a little bit, comment on the shared decision making. What is it about, and how is it different from normal standard of care. Now, the relationship between doctors and patients has always been a topic of concern in medicine. And we know that, poor communications led to all sorts of things, poor health outcomes, medical information that has been missed or misunderstood. And in some instances, it's resulted in treatment delays, in some instances, inefficiency in diagnosis and treatment, and indeed conflicts in some cases leading to medical legal challenges. In fact, if you look at medical legal, cases that we have, quite a lion's share of that results from poor communication. And again, every patient's expectations are different. The one patient expectation is different from the next patient. Now, patient-centered approach represents a new way to improve service delivery. And in this model, autonomy is seen as fundamental, and relationship is seen as a partnership between the clinician and the patient. It's indeed a joint decision. There's no clear wrong or right answer. And the correct decision must depend on the patient's own specific needs and preset goals, which are different from one patient to the next. What is it? The shared decision, what is it really? Shared decision making does not really suggest or induce or encourage, patient to choose, or follow a particular option. It is really not intended to replace medical staff instructions, and each patient consideration expectations, as I've already indicated, are different, and this has to be taken into consideration. So this was a table, a publication of healthcare, a manual, basically looking at what shared decision-making model for treatment of patients. Basically looks at the doctor's role, the patient role. And if you look at a traditional medical model, the doctor's role will be initiative, only explains the selected information to the patient and choose the treatment they think is best for the patient. So in other words, the doctor knows best. Now, in the shared, decision-making model, here the doctor will explain all information and treatment possibilities to the patient, can recommend an option, work with the patient to determine the treatment method. So that's really the shared decision. An informed consent medical model will be, is really is more passive. It explains all the information and treatment possibilities to the patient, and withhold advice. Do not make any decision. Now, the patient role, again, in a traditional medical model, usually the patient listens, is told by the clinician what to do, accepts the advice of the clinician. It is necessary to cooperate with the doctor during the patient recovery. But again, the patient's role in a shared decision-making model would be really receive all information. They will have their own judgments about the hazards and benefits of a treatment option, and the patient will discuss their preferences with the clinicians and determine the treatment with the clinician. So basically, there is a bidirectional information exchange. And this is really the best way to make a decision. It's intended to make patients make value-based decisions together. It is indeed a win-win decision situation. It explores care or treatment options. It looks at their risks. It looks at their benefits, and of course discusses the choices available. So at the end of the day, a decision is reached together. Now, there are several benefits of shared decision making. And one of those, understanding what's important to both the clinician and the doctor. So we'll explain this a little bit in the context of taking informed consent, and feel supported and empowered to make important choices, both the patient and the physician, and tailor the care of treatment to the needs of the individual. So that, as I said, the needs of one individual is very different from the needs of the next individual. But it's important, therefore, to individualize and tailor your treatment approach to a specific patient. Now, if you look at the people who are delivering care, like clinicians, the benefit of balanced professional judgment and expertise with the wish and needs of the people receiving care. For those that are receiving care, it takes into account your needs and what are your preferences. For example, if I'm going to have a laparoscopic cholecystectomy, what are my preferences? Is recognize the right to be involved in the discussion and make decisions about your care. And patient decision aids support conversation and help patients make informed choices. So with all of this, what is required for informed consent? Now, there are ethical requirements for informed consent. And there are four main principles of medical ethics. As we know, it is really around justice. It is really around non-maleficence. It is around autonomy. It is around beneficence. Now, autonomy really is the main ethical consideration underlying informed consent. The patient must be granted that autonomy. Now, for consent to be informed, patients rely on the information provided by the doctor. So it becomes crucial, therefore, to discuss and unpack whatever procedure you're going to do in the language and the technical terms that are understandable to the patient. And it's important, honesty and truthfulness are required to make the process of consent, of informed consent, valid. So it is not correct to say, I'm going to remove your esophagus, as a little minor procedure here and there, and there, we must be honest, we must be truthful, and open when we discuss, with the patient, and we discussed informed consent. The requirement of informed consent, again, and the basic difference between consent and informed consent is the patient's knowledge behind the consent decision. And that is why it's called informed consent. So the patient has got to have fundamental and profound knowledge of what is going to be done. So it takes time. You need to really sit down with the patient, as I'll explain in the talk today. Now, it requires the patient to understand the diagnosis. What is it? What is wrong with me? I have a pancreatic cancer. I have, a benign tumor of the breast. I have, a benign tumor of the stomach. So it requires the patient to understand that what is a tumor? What is it? And the diagnosis, and also if there are uncertainties about the diagnosis, which sometimes occur, we're not very certain. We think this is a gastrointestinal stromal tumor, but we're not very certain about it. And those uncertainties must be explained to the patient. So that, again, as I said, is a partnership. You take the patient along with you, as well as, the different treatment options. For example, what are the different treatment options, including no treatment at all? In other words, can I leave it alone, doctor? What's going to happen to me? And what are the potential consequences if we, opt for a non-treatment option? What are the advantages of this procedure you're talking about, or treatment? Equally important, what are the disadvantages? If I don't get this treatment, that you are proposing, doctor, what's going to happen to me? And then what are the achievable outcomes? I think it's all well and good and say, there is a 1% chance of dying from, a 0.3% chance of dying from a laparoscopic cholecystectomy. That is achievable in Toronto, in Canada. That's achievable in Sydney, Australia. In South Africa here, between you and me, doctor, your own experience and results is, these results that we're talking about, are they achievable? So I think it's important to convey that to the patient. And amount of information required to make consent may vary. It depends on, for example, the complexity of a treatment. Again, it's not only about operation. Informed consent is also about non-operative treatment strategies. The complexity of treatment may require that you really sit the patient down and be able to explain exactly what the operation or the treatment options are, what are the potential complication, advantages, and so forth. And of course, the risks of treatment as well, as well as the patient's wishes. What are the patient's wishes? For example, he may be a 97-year-old who's got great grandchildren. All that, he wants, he wants to spend his last few days with his grandchildren, doesn't want to go through all of this. So that becomes crucial, in factoring in, the management strategy and pathway of what you're going to offer this patient. What are the patient wishes? Now, Then the critical question then becomes, how much information is enough? When if you're talking about giving information, what is enough information? Of course, individual patients will have different intellectual capabilities. They will have different understanding of their illness, even with adequate explanation. And that has got to be factored in. So therefore, it becomes crucial to tailor your information provided to the individual patient and the current situation. Then how do we judge if the patient has understood the discussion of informed consent? Now, to judge if the patient has understood the info given can sometimes be very difficult. I've had this experience where, you speak the patient's language, you try to explain in non-technical terms for the patient to understand. And when the patients are asked, they say something different. And there are many confounders to this. They're often very scared. There's all sorts of things, that plays in their mind, when you discuss. So sometimes they're not listening. They're concerned about what has just been disclosed to them, in terms of diagnosis. So there are all these potential confounders. And that is why, you need the third-party input, trusted third-party input, as I'll indicate when I unpack, the various domains of informed consent. That's so that the patient, somebody corroborate, what the doctor has said to the patient. This leaves the physician in doubt if the patient truly understood the information sometime. And partial and incomplete information can also be invalid. If you give information that is not complete, or is partial, certainly may not have the situation. And the principle of an absolute right to consent could be easily undermined by partial information. If you don't give all the information, certainly this can undermine the whole process of informed consent. And of course, we know it's highly dependent on the willingness to provide full information. Often we underestimate the intellectual, capabilities of our patients. The fact that somebody cannot speak English very well doesn't mean they're intellectually challenged. It's just language issues. So therefore, it is important that, when we discuss with the patient, we don't assume that they don't understand. We must be able to provide, the information in the language they understand, in terms that they will be able to understand, what's the, and that can be done effectively, even to patients that have not been to a formal school. The patient's capability to understand and weigh up the information also, plays a critical role. Now, just maybe a brief word on legal framework of informed consent. Now, a medical intervention without valid informed consent in South African law is a criminal offense. In fact, if you operate without it, you can be charged with battery or assault. And so you can find yourself, in prison for assault. And if you look at minors, they give consents, the age is more than 16 years, depending on their understanding, and of course, acute and permanent lack of capacity, certainly may pose a challenge. Now, there are all these things, that myriad of challenges, in our area of work, that often confronts us, and one of those is, when is consent valid? And of course, the consent is valid when the patient is competent, mental capacity in decision-making. So if for whatever reason, head injury, the patient is obtunded, that consent will not be valid. If the patient has ability, must have ability to understand, if they cannot understand what you say, that consent is invalid.
Yeah.
And the patient must be able to make reasonable decision on the basis of information given. All right. Now, the patient must have sufficient information to make a choice. The information provided should include an explanation of the investigation, the explanation of the diagnosis, explanation of the treatment modalities. It must be an explanation that covers, the probabilities of success. What are the probabilities of success? And we need to quantify that. So we can't say, well, this is highly successful. But what highly give the patient context. In other words, it's successful in 95 out of 100 patients, something like that. So it is unsuccessful in 5% or 5 out of 100 patients. So patient need to be able to weigh the risks, in the language they understand, in their minds. In other words, I have a 95% chance of success and a 5% chance of failure. So I will take my chances, and it's a different scenario if you're telling me there is an 80% success of failure and 20% of success. I'm not so sure I can go with this, So it must be quantifiable, or so that the patient can understand. And of course, the risk of failure. What is the risk of failure? Every intervention has a risk of failure. And once again, that needs to be quantified in terms that patient can understand very clearly. And what is the harm associated with options of treatment? What are the harm? And all of that needs to be discussed. The patient must be able to give their consent freely, without coercion, without intimidation. Sometimes, as doctors, we come, we're going to die. If you don't do this, we're going to die. I don't think that's the correct thing. Again, there mustn't be coercion. The effects of what the procedure entails, and what are the potential benefits, what are the harm, associated with the procedure, must be explained in the language that the patient, understand, in an environment that is free of coercion. As I said, shared decision, collaborative approach to communication, again, it incorporates patient values, what are their preferences? Their aim is really to ensure that the patient understands what the clinician is saying, and that the patient align their preferences with their treatment choice. And of course, we know that this improves patient outcomes. Now, what are the key components of shared processes, informed decision? It really focuses on how clinicians foster patient participation in reaching treatment decision. Again, very, very important, that approach. And despite the need, there are very few studies that have looked at this particular question of informed decision making and incorporate that into informed consent. So as I said, is really the intersection really on informed consent, informed decision making, and these are very important. So I'm going to just maybe unpack a little bit, what, Dr. Braddock's, called, the 9 elements, of informed decision making, right? And which really are key when we're going to talk to a patient about informed consent. So firstly, you need to, again, unpack what is the patient role, In any discussion with the patient, what is their role? In other words, the patient role in the decision making. For example, if I'm saying I'm going to do appendicectomy on this patient, what is their role, in this decision that we are making, all right? And the second thing is, what is the impact on daily living? So if I'm going to offer the patient a laparoscopic appendectomy, how is that going to impact on their daily living? Immediately post-operatively, few days, few months after the operation, and long term. For example, if I'm going to do a colostomy, I bring out a stoma, this is going to fundamentally impact the patient's daily living. Because now suddenly they're going to wear a bag, when they, sleep, this bag may come off, all sort of mess. When they want to become intimate with their partners, this is the problem. When they want to go to the restaurant, this is the problem. When they want to go to church, this is the problem. So that aspect needs to be discussed with the patient up front. What is the impact of the decision about surgery on the patient's daily living? And the third, element of the Braddock scales of informed decision making is really the nature of the decision. The main clinical issue and the nature of the decision that's going to be made. And that again needs to be incorporated. And very important, what are the alternatives? If I say the patient has, for example, acute appendicitis, what is the alternative? Is there a non-operative alternative for acute appendicitis? The answer is yes. So in other words, we say we've got appendicitis, but there is a non-operative strategy for acute appendicitis. We can treat it with antibiotics, provided, on cross-sectional imaging, there is no obstruction of the lumen of the appendix. We know, there's good success rate in the literature, although, there is high recurrence rate, but, it's possible. So in other words, we can't, again, we shouldn't coerce the patient. Say, no, we want to operate, especially, in the private sector where there is also element of finance, and we tend to push the patient to a decision that is going to be more beneficial to us, maybe less so to the patient. So I think it's important, therefore, to unpack and be able to discuss comprehensively alternatives, if they are there. And of course, the fifth element in the broader scale, on informed decision making is around pros and cons. In any intervention, there are pros. Of course, there are cons. For example, if you say to me, I'm going to do endoscopy on you, what are the pros? What are the cons? The patient can have, for example, colonoscopy, they can have a perforation. Although it's rare, it's a possibility. And this needs to be discussed with the patient. And when the patient now consents, give informed consent and signs, it has got a very thorough understanding of both the pros and cons of the procedure. And then the sixth element, is around uncertainty. Because in medicine, there'll always be uncertainty in some instances. I think this is acute, cholecystitis. It may not be acute cholecystitis, it may be something else. If there is uncertainty, again, remember, we are also humans. We need to put that information across to the patient. Patient must understand that the doctors, I'm not sure here, but I think I'm 70% sure it may be something else. So that, if alternative treatment strategy has to be considered, the patient has a clear understanding upfront, that there was an element of uncertainty there. And then, of course, in all these discussions, remember there are all these confounders. The patient is very anxious, there's all sorts of things listening. Sometimes they are not. It's a very intimidating environment to have an interaction between the clinician and the patient, although we try to put the patient at ease. So it is important, therefore, to assess understanding. How much did the patient understand? So again, the patient should be asked, do you understood? Could you just repeat to me, what did I say? What are the things to assess the level of understanding? And sometimes you get very surprised, you thought, you were at the patient's level, only to find that they have understood very little. And of course, patients do have preferences, because remember, when you discuss informed consent, there are all these variables, all these options, all right, including non-operative strategies or option, operation, open operation, laparoscopic, minimal access, all sorts of things. For example, if you look at an aneurysm, abdominal aortic aneurysm, there are all these strategies available now. I can do an open operation of an abdominal aortic aneurysm, put a graft there, and resect the aneurysm and put an interposition graft. Or I can put an endovascular, stent graft. But the problem with the endovascular stent graft is all these things, endoleaks, it can leaks from the proximal part, distal part, it's all sorts of problems. And it is often recommended for patients that it's not ideal for that are elderly. For example, a young man, 55, who's got an abdominal aortic aneurysm is probably, better off with an open operation. But an open operation has got this morbidity. There's a pain. There is maybe a 1 to 2% mortality rate. So these things needs to be discussed with the patient, and the patient then will be able to say, my preference, doctor, despite what you have said, despite the pros and cons you've mentioned to me, I prefer this one, doctor. I prefer this one. As I said again, it's a joint decision. And then, of course, the last thing is the trusted other inputs. Because as I said, the patient, doctor, interaction is a very intimidating environment. So sometimes the patient doesn't listen because they see this doctor, they get overwhelmed and overawed, by this interaction. So therefore, a trusted, other inputs. For example, if it's a partner, is a wife, is a husband, is a grown-up child, and then we're able to listen. And that is why when we discuss this thing, there's a trusted member, who's present, who will be able to corroborate what you said and be able to explain to the patient. And the patient must be given time to consider what has been said. Now, informed decision-making, again, as I said, the patient role in the decision-making, and again, the pros and cons, Again, as I said, impact on daily living, nature of the decision, alternatives. I think I've already covered that. Now, that's really in shared decision. But now there are 11 domains. The American College of Surgeons have put together, what they called, the 11 domains of informed consent. So in other words, if you have not discussed these 11 things, your discussion with the patient in terms of informed consent, many authorities will consider as suboptimal. The first thing, the patient must know the nature of illness. Now, this is now comes administratively in your records, so where you're going to now write down what we have discussed, again, preemptively for medical legal challenges, because today, patients are litigious. They all go and, challenge you that you didn't tell them about 1, 2, 3. So these are the 11 things. The American College of Surgeons, urge you, or make it very clear that these 11 things must always be in the informed consent. The first one is nature of illness. What is wrong with me? There's acute cholecystitis. I must be able to discuss in non-technical terms what is acute cholecystitis to the patient. And then I must cover that in the nature of the operation. I must cast the risk of mortality, because even circumcision has got a risk of mortality. It may be 0.00007 or 0.1, but there's a risk of mortality. For example, if you look at, Whipple resections, I think many people say the risk of mortality, the international literature will say maybe under 5% mortality. So again, we must be able to quantify that, the risk of death. I think it will be, not, professionally honest to say, no, there's no death. I'm going to do a breast mastectomy, there's no death. There's always a risk of mortality. So in other words, if you haven't discussed that with the patient, risk of mortality, that is, even if it's 0.003%, it must be discussed. And one of the better way of laying, because again, when you discuss it in raw terms, it tends to frighten patients. Nobody wants to hear that this operation I'm going to have has got a quantifiable risk of death. Nobody wants to hear that. But one of the ways to get around it will be, it's actually, even though it's got a risk of mortality, it's actually safer than crossing a street. But have you ever, wondered or thought about it? Every time you cross, a road traffic street, a road, there's always a risk that the car can hit you. There's always a risk, always. If you travel on an aircraft, there's always a risk that the aircraft can come down, you can die from aircraft pressure. But it's really about the quantum of the risk. So therefore, the risk of mortality has got to be covered in informed consent. And what are the common complications? You have to write that in a preoperative form. It must be written, common complications. For example, if I'm going to do a laparoscopic cholecystectomy, one of the common complications and the very feared one is bile duct injury. So in other words, did you tell the patient that there is a bile duct injury risk? And the risk is about 0.3%. If you didn't do that, then your informed consent is suboptimal. And then the patient must understand the risk of benefits. And then, of course, what happens if I don't get treatment? If you say about gallstones and I don't get treatment, what happens? Am I going to die, doctor? What's going to happen to me? The consequences of no treatment. They also want to know the hospital stay. If I'm a CEO of a company, I'm going to do a inguinal hernia repair. I've got, 40,000 people working under me. I want to know how long am I going to be off work, and I'm going to be in the hospital stay. And then also, how long is it going to take me to recover? And of course, did we discuss the alternatives to the patient? Did we discover that? What about the non-operative alternatives? And of course, the benefits. So these are 11 domains. I think for the colleagues, especially in the private sector, it is very key that, in your preoperative assessment, that record that's going to go into your file must contain these 11 domains of informed consent. And when there's a, for example, CAMBES, medical legal thing, you basically yank out a record. These are the things I've discussed with the patient. Ideally, the patient should sign at the bottom. But if this had been discussed, including the common complications and so forth, that increases, the chances of success in the case of litigation. So I'm just going to go to now, briefly now take you through a clinical scenario of how, we take informed consent. The first case is a 35-year-old female patient with no comorbidities. She presents with symptomatic gallstone disease, and this requires laparoscopic cholecystectomy. Now discussing how you would go about obtaining informed consent. Now, sometimes, even in the college exams, we sometimes, ask the registrars, you want to do laparoscopic cholecystectomy. Can you just maybe take us through the elements of informed consent? How are you going to consent this patient? So again, I'm going to go back now, again, it's a cholecystectomy. So I'm going to go back to the 11 domains, as I said. So the first thing now, here I am. I'm Dr. So-and-so. There's Mrs. Mazubugu. I'm Dr. So-and-so. We've been, remember we've done, ultrasound. Remember we had this pain that was so severe. We did ultrasound on you and we examined you and we came to the conclusion that your problem is gallstone disease. But what is gallstone disease? So that addresses the first domain, which is the nature of the illness. So again, in non-technical terms, I'll be able to explain that. If the patient has got multifibroid uterus, what is multifibroid uterus? And how did you arrive at that diagnosis? This is what is said. This, is because of high cholesterol level, now your bile has become thick, it has crystallized and formed little stones like little gravel. Now these stones, every time the gallbladder contracts to squeeze bile for digestion, these stones block the opening. That's why you're giving pain. That's what gallstone disease is. And then if you leave it alone, you're going to get this pain repeatedly. And they say always a small chance that after maybe many years, 10, 15 years down the line, you may have, it may cause cancer of the gallbladder. But that's not a very big risk, But the problem is this, you're going to get repeated attacks. Sometimes it can be so severe that you end up, lying in a hospital, the gallbladder swells up, it becomes thickened, it becomes infected, So that addresses number one. The second thing is the nature of the operation. Now, what are we planning to do? We're planning to do what is called a laparoscopic cholecystectomy. What is this? This is removal of the gallbladder. But but God has made a human with the gallbladder. How is it going to live without a gallbladder? So fortunately, gallbladder is one of those organs that you can safely, without major problems, live without. It's almost like an appendix. Although in some instances, very rare instances, you may have a little bit of diarrhea every now and then, but very occasionally, it is one of those organs you can live without. So what happened, because its function is to store bile, excess bile that comes from the liver. So if you remove the gallbladder, excess bile basically will go down the gut. You pass it when you go to the toilet. It's not a major problem there. All right. But you still have bile because it comes from the liver. All right. So the nature of the operation, we're going to remove this gallbladder because the problem is if you cut it open, we just remove and stitch it close again, it's going to form more stones. So the best way was to remove it. And this operation basically is done through a camera. So the camera the size of a pan, we make little puncture holes, about 4 of them, one around the belly button here, one on the right side below the chest wall, the other one on the left side. So we put about 4 little openings, and then basically we use small little scissors, the size of a pan, to dissect it out, and then we use what is called titanium clips. We clip where it joins the main little duct that takes bile from the liver. So this is called endoclips. They're called titanium. Again, said, but doctor, you're going to leave clips in my abdomen. But clips, these are no problem. They don't cause tissue reaction. Remember, when you have a fracture, they put a big metal rod in your bone, and you can still live with it. This one has tiny little clips, so they really don't cause much problems. And then what are the common complications? Of course, complications are general. There's those that are the big complication, general and specific one. Let me start. General is complications that, okay, it doesn't matter which operation you have done. Remember, they're going to put the breathing tube in you here. They give you medication, put the breathing tube, they put you to sleep, all right? And then, we then, make a little hole and put a camera and then remove, the gallbladder. So one of the risks is sometimes we can injure the common bile duct. But let me quantify this risk to you. Injuring the common bile duct, is a real risk, but is rare. It's almost like 3 in 10,000. So in other words, we have to do 10,000 operations and only 3 patients. So it's about 0.3%. So it's a very low. It's actually even safer than crossing the street. Crossing the street, you can maybe hit by a car, so that's really the common complication. And then of course, hospital stay, you're going to stay about, at maximum 2 days if there are no complications. But remember, there may be some complications. Sometimes you may have infection, you may have blood clots in your legs, so you may stay about two days, sometimes 3 days, if there are no complications, about maximum 2 days. In a post-hospital convalescence, it's about 2 weeks, but usually give you more depending on what type of work do you do. If you do manual work, we might give you maybe 3-4 weeks or so for you to recover. Are there alternatives? Now, if you look at the literature, there are alternatives for gallstones, but they're not effective. In the 90s, they used to talk about extra shockwave lithotripsy, a little machine here that breaks the stones, but it is not effective. In other words, about 20%, 30% effective. So it's not very effective, that alternative. And then there is this dissolving agent, that you take, but all of those are not so. So the alternatives are there, but they are not effective. So what is effective is to remove, this gallbladder. What are the benefits? The benefits would be that you are going to be without pain, and then the risk of cancer, even though it is small risk, we eliminate it, completely. What are let's say what are consequences of no treatment? Let's say we don't treat you, what's going to happen? You're going to end up with recurrent pains. The pain may be worse. It may sometimes get infected, and then you get, admitted to the hospital because of this repeatedly, and then of course long term, there's that risk, ever-present risk of cancer of the gallbladder. So that's in a nutshell, how one would take a patient through a informed consent process. Now, the one that the patient now signs, which Clinics Health Group has, and many hospital group have, it's really not informed consent. Basically, that's just a signature. But this one must remain in the patient file. So in other words, if you're operating a patient, especially in the private sector, not even the government sector, public sector, if you don't have this, you really haven't discussed informed consent. If the patient sues, legally, you're in trouble because you haven't. Where did you discuss it? What did you discuss? Did you discuss the nature of the operation? What about the risk of mortality? Did you discuss all of that? The common complications and so forth. So I'm going to go to the next case very briefly. So this is basically how I was going to approach that. Now, the second clinical case is a patient who's a 45-year-old man. He's got class 3 obesity and type 2 diabetes, considered for laparoscopic Roux-en-Y gastric bypass. I think it's the same story again. If you were going to do, for example, a hysterectomy, it's the same. If you're going to do myomectomy, it's the same procedure. If you're going to do pancreatectomy, it's the same procedure. If you do femur fracture nailing, it's the same thing. So you go to the same 11 domains once again, as I've indicated, nature of illness, nature of operation, risk of mortality, common complication. Does the patient understand the risk and benefits? What are the consequences of no treatment? What about hospital stay? What about post-hospital convalescence? What about alternatives, non-operative alternatives, and then the benefit? Yeah, I think I didn't want to take a lot of time to allow, discussion. I would like to thank you for your attention, and I'm looking forward really to the discussion that may ensue after this presentation. Thank you very much.
Well, thank you very much, Prof. Koto. That's quite a lot of information and quite helpful for all the practitioners who are logged in this evening. And I believe that we're going to go away home with a lot of information, new insights into how to obtain informed consent. And as you said, there are some places where perhaps what we've come to practice as informed consent, what you document as informed consent may not be sufficient. But I'm sure that's a question that how do you go about working on that and improving on that? Because I think you showed us the examples and the modifications of informed consent documentation. Is there something that we can look at that there are lots of questions as to say, how do you obtain informed consent pre-operatively or post-operatively? Whether you can get it post-operatively. But I think just a document, just quite a number of those, the product model that you've spoken about, the informed consent document may not necessarily cover all those, as you've come to know. And I see Prof. Solira Tamana's hand is up. Maybe let's hear you, and then I'll ask Prof. Soli Tamane to respond. Prof. Koto?
Sorry.
Yeah.
No, thank you very much, Dr. Bila. I think certainly this is one of the things as a member of the risk committee of clinics, also to put together, for clinics health group, so that colleagues that practice, within the hospital group really can look at that, and see whether they can adopt this in their own individual practices. Just recently, or a few days ago, I was in the Northwest High Court, as an expert witness, on a case, a step that was done in Northwest. And it's amazing how, the senior counsel, how, vicious they are, in terms of, how the doctors, went about, before the operation of the patient. So I think, the landscape, in South Africa has changed fundamentally. Now we have even, people being arrested, for treating patients when patients, so the landscape has changed. So it really calls on us to change in our tact in terms of how we interact with patients. So I think it really requires us to look at and self-reflect on how we practice medicine today, because things have changed fundamentally. Thank you.
Thanks a lot, Professor Ratamane. See, your hand is up. If you can unmute yourself and post your questions or make a comment.
Thank you very much, Dr. Bila. Thank you, Prof. Koto, for a very comprehensive presentation. I just want to support what Prof. Koto said, because we are having too many doctors reported to the Health Professions Council because of failure to document, the process of informed consent, what was consented to, and so on. I think it's important to actually document briefly all those 11 domains. Now, Prof. Koto, what sometimes comes up as a problem, patients who are looking for money, who are pro-litigation most of the time, they will look at that and they'll pick something small that may not be a regular complication of the procedure. And it comes up and it says, the doctor didn't tell me this will happen. How will you, in your documentation of the domains, cover unexpected complications?
Yeah,
thanks, Prof. Koto.
Yeah, thank you very much, Prof. Rataman. I think that's an excellent question. I think the point is that it's not possible to cover every little complication that may occur in a procedure. It's not possible. I think, and these 11 domains, as crafted by the American College of Surgeons, I think takes into account the major issues. And when it comes to litigation, if you've discussed mortality, you've discussed, the common complications, and a very unusual complication occurs, I think the court often have a very sympathetic, approach to that kind of. I mean, it's not possible, because even to write everything, you write a whole textbook. You write, and it's not practical really to document every little complication. But I think those 11 domains cover really the major issues around perioperative care. Yeah. Thank you.
Thank you, Prof. Koto. Also, just the last thing from my side.
Okay.
When you document these things, you date and sign on that day. If, for instance, the investigators go through your notes and they find the signature, but there's no date, they'll say, you just wrote this yesterday. It was already written at the time before the operation was done or the procedure was done. So it's important to date and then sign. Thank you.
Yeah, thank you very much, Prof. Rataman. I think that's an excellent point, critical point really, to sign and date it and the time, you know,
Yes.
and that must be written as well. Thank you very much.
Thank you.
Thanks a lot, Prof. Rataman, for that comment. I think indeed, living to the HPCSA motto of protecting the public and guiding the professions. And so I think that's one who just tipped us as healthcare professionals, that make sure that it is documented and signed and dated. Because if it's not done that way, then you're prone to liabilities in case there's a litigation.
Yes.
Now this question, the next question, Prof. Koto, I'll come to you, Dr. Tutu. It's about from Bongani Shabango, Dr. Shabango. He wants to know, please advise on how to avoid this emerging criminalization of doctors or surgeons, and then how doctors can protect themselves against such using the consent form. We've seen that quite in recent times, that doctors have been charged with murder. I think that's what I think the doctor is trying to, or what the doctor is saying and alluding to.
Yeah, I think it's a very unfortunate, incidents, that we are now increasingly witnessing in South Africa. We never had this before, and I believe there's no doctor who wakes up, in the morning and sets out to harm a patient, intentionally. And murder is a deliberate, intentional act of ending somebody's life. But in the pursuit of trying to help someone, and a mishap happens, including death, it cannot be called, murder. And this issue really is something that we've witnessed, in countries like United Arab Emirates, Iran, where issues of other religiously Sharia law things. We've seen Professor Karabos, who was from the Red Cross, who was arrested en route from his son's wedding in Dubai, because of a patient who had died 10 years earlier, from leukemia. So we see in this problem and this trend, rearing its ugly head within South Africa. Now, I think talking now as the current president of the Association of Surgeons, certainly there's been, lots of moves really to, including, Surgicom and other societies, to lobby government, to really look at the legislation. You cannot criminalize doctors, because if you do that, very few people will be willing really to take up the challenges of treating patients, or people will be risk averse. There will be a risk of, they will see a lot of risk aversion, where if you come, you want an operation, you've got comorbidities, I'm going to run away and not want to try, because if patient dies, then I may be, charged with murder. So it is a problem. I think the question is, how do you avoid that? I think the policymakers, we have to start there with the policymaker, the legislation. Legislation needs to be changed, and changed urgently. You cannot criminalize, doctors, and even a judge of element of a judgment error is not negligent, because if I believe that due to my according to my experience, this is the way to present, I may make a judgment error. That's not negligent. It's a judgment error. Even with your child, you can make a judgment error, do this, and the child, bends his finger, but it's a judgment error. It's not negligent at all. So I think it's a very unfortunate, trend that we are witnessing within South Africa. But I think it requires, lobbying government and legislation. Legislation has got to be changed urgently. Fortunately, the past Minister Motsoaledi, really had made a comment on this and actually raised his concern around criminalization. I think the current minister as well, criminalization of the profession. So I think it really requires, legislation. But I think in terms of informed consent, I think Professor Rataman has already indicated, I think it's important that all those domains be covered and sign them and date them and put the time there. It must be in your records at all times, so that, if your records are subpoenaed, you have that information available.
Thanks, of course. And Nomzama Tutu, can you come? You had your hand up, and I see that you also posted a question related to criminalization of doctors, and your fear is that if this is allowed to continue, we won't have any more young students going to the medical profession. Can you come? Yeah, sure.
Thank you so much, Dr. Bela. I must applaud the presentation by Prof. Koto. I think I was one of his students. I don't even think that he could remember me. You know, with my gray hair now, I don't think he'll ever be able to see me now.
You can switch on your video. We can see you.
You can see
it's
me.
Possible. Switch on your video. Let's see you.
Well, I'm sitting on, but I'm not sure if you can see me. I don't know what's going on here.
Oh,
anyway,
okay, that's fine. Go ahead. We can see you. Yeah.
You know, colleagues, we are confronted with a very, very difficult situation in this country. And we need the Health Professions Council to protect us. We need, as ourselves, when we conduct our duties and render the services, we must make sure that everything that we do it to the T, so that we are able to defend ourselves. I am very happy that the last statement that Prof. Koto made, which I was going to say, is that record keeping, history taking, all the documents must be up to scratch. That's what I wanted to say, including writing the time. When we were trained and I entered my internship program at King Edward, we would put the time, everything, because you must always know that when you are confronted with a patient, anything can go wrong, even if it's not surgery, even if you are, you know, in medical wards and everything, anything can happen. So I think for us, the takeaway from this webinar is that we've got to be very, very precise on what we do. We've got to, you know, express whatever our opinion in a manner that will be able to defend us, even if we were to be taken to court. And at the same time, record keeping is very important. But what has been happening and what I've seen is that there have been some collusions in hospitals with the lawyers, with the nurses, and with the staff, the other staff in hospitals. That has been happening. We must be very, very careful. So I think it's also important that we also have our own records that we keep. Like if you've made a patient sign the informed consent, then we make a copy for our own records in our rooms, so that is kept in the file. Because if that disappears in the file that is in the hospital, then you have a problem. They will say you never did it, you know, because there is collusion that is happening, because people are engaging in criminal activities like you don't believe. So that's what I thought I would bring forward, that let's make sure that everything that we do, we are doing as we were taught. History taking, clinical examination, everything done to the T. Whatever we do, make sure that it's all recorded. You make copies if you have to. Thank you very much, Prof. And
thanks, Dr. Tutu. Quite a mouthful. And I think it brings us to said that you need to write it. If it's not written, there's a problem. But now Dr. Nana says, is verbal consent acceptable according to the law, or must consent be in writing? We've spoken about that, Prof. Koto, that it must be in writing.
Yeah, I think it certainly it must be right. Obviously, it depends. For example, a dire emergency is where the patient's life is at risk. In some instances, where the patient is not capable of giving consent, we may get the superintendent, we may get the parents, we may get the relatives, to give that. But here, really, I was largely, addressing, elective procedures, for example. I think that's very critical. I think Dr. Tutu is absolutely right that there's collusion, all sorts of things, records disappear, and all sorts of things. And I think we need to protect ourselves, make sure that we have copies in our own files, in our own private files. Yeah, thank you.
Sure. Thanks a lot. The next question is, okay, let me take Dr. Mabaso. Dinyiku Mabaso, come. You can unmute yourself and ask your question.
No, thanks, Dr. Bila. Prof, thanks for the not so easy topic, I must say. Some people say informed consent is probably the most difficult topic because it involves so many factors. And some say we're in the twilight. The minute we think we understand it, more things come into the picture. But what I wanted to just emphasize is the fact that patient autonomy is what the South African Constitution wants to bring, as opposed to initially where medical paternalism was the main one. So the fact that you emphasize the point that patient must truly be informed and be parties to this process was a very good highlight. On the issue of how much to disclose, the issue about how uncommon is it a potential risk? Those are still also quite gray areas, and I agree with you fully that the medical profession needs to come in and make its grounds on how it should be understood, because mainly we're not understood by the legal profession. And if you're going to leave it to the legal profession to interpret our profession, that's where the problem comes in, So we need to come in as a profession to say, and that's why there's a health professional council, to say the courts are basically saying it's not our duty to judge what professionals do and their discretion. Go to the boards in the council, let them deal with it as fellow professionals. But as we've highlighted here, unfortunately, in cases of death and culpable homicide, the biggest problem currently in the country is, and South Africa has been doing well. We've always used the Inquest Act, death due to unnatural causes, then the inquest will come in and prosecution if need be. But usually it wouldn't come in because negligence would, even if negligence would be part of it, it will be culpable homicide, and it wouldn't go that far. But the problem, unfortunately, with this current dispensation is no one can be stopped to access the courts. So people are starting to learn that you can bypass the inquest process that South Africa has been using over the years, and it has always managed to solve most of these medical legal challenges. But direct access, which is a constitutional right to say someone died, I'm not going through the inquest, I'm bypassing it. I'm going directly to the courts, and I'm coming to litigate. And unfortunately, the patient has a right to do that, of course, on behalf of the deceased. Unfortunately, the burden and the stress that brings to the accused in that case, it becomes so heavy. You can't practice having that cloud around you, and it doesn't mean you are guilty. You're guilty until proven guilty, innocent until proven guilty still applies. But the burden and the stigma around it, it's what we are not used to, and I don't think any of us can take. So I agree with you when you say legislatures have to look at this one closer, to say much as the patients have, or the next of kin or the dependents have a right to bypass the inquest process, what the direct access to court as far as the criminal process is concerned, and what it does to individual practitioners, it's beyond reason, and it affects delivery of services, of course, because you have to close your practice at that time. The SPPSA has to conduct its own whatever. So I think the theme here is let's get hold of this process ourselves and try to make the legal profession understand where we come from. And in conclusion, to assist, to say, most of the time, any case, anyway, is judged on its own facts and circumstances. So it's very difficult to put things into a general context. Your laparoscopic procedure will be different with your colleague's one, and the circumstances and the facts will differ. But if you want to cloud them into the same topic, it's not going to work in medicine. So I just want to say I acknowledge and thanks for the great topic to bring it to the highlight. Thanks, Dr.
Thanks a lot, Dr. Mabaso. And I don't want to comment, Prof. Koto, but I think you said quite a mouthful and also posed a question and a challenge to the regulators and also to us as practitioners to see what do we do in these situations.
Yeah, I think he said a mouthful, and I agree completely what Dr. Mabaso was saying. Thank you.
Thanks a lot. Thanks, Dr. Yeah, going back to the Reverend Nana, can a member of the nursing staff take an informed consent for a surgical procedure, or must it always be taken by the surgeon doing the procedure?
Yeah, I think that's an excellent question. I think the person who's going to do the procedure should be the one who takes informed consent. Obviously it varies, for example, in academic centers, there are teams, but again, during the ward round or preoperative visit and discussion, these things are discussed with the patients in a group. And then the administrative part, which is really the actual signing, if the nurse was part of that administrative process where those 11 domains were discussed with the patient, and then all that remains really to sign. So that administrative part is not taking informed consent, but basically carrying out the administrative process of informed consent. But the informed consent must be taken by or done by the doctor who's going to perform the surgery.
Yeah, the surgeon who's going to be doing the operation should sign. The nurse can sign as a witness.
Correct, yes.
Yeah. Another question from Matsidi Somtezuka. He says, I think the first thing to be done is confront the elephant in the room. How comfortable are doctors to tell patients when they don't know that death is always a risk to anyone who's alive? That death, you mentioned it slightly in your talk about the probabilities of death in every procedure or situation that a patient may face.
Thank you.
Yeah. Go ahead, Prof.
Yeah. I think you're absolutely correct. And another thing, it calls on us really because I think it's something that perhaps we don't, emphasize a lot in our areas of work. To be able to talk in those terms of quantifying risks, including mortality. So I think once we get into that habit, we're able to know, for example, if I'm going to operate gallbladder, the risk of death is 0.77%, 1 in 10,000 or something like that. So, slowly, once you make it a habit, and a lot of other procedures, then we're able to quantify them. If I'm going to remove a colon of the patient, the risk of death is around this much, and then of course we'll go and check that up, before you discuss with the patient. If you've forgotten, there's always material to refer to. But again, it needs to be contextualized, because if you say 1 in 1,000, people may not be able to, intuitively, be able to put that context, what does it mean? What does it mean? But if you say to them, it's probably safer than, crossing a street, because if you drive a car, for example, there's always a risk that you get a car accident and die. There's always that risk. But we drive cars all the time, isn't it? So the risk is there, but it's not a significantly high risk. So it is a standard risk, of death. So the same with an operation, like crossing a street, taking a flight from here, from Joburg to Cape Town. How many people think of dying to take a flight from Joburg to Cape Town? So we never even think about that, but there's always a risk. So I think it's an operation. Yeah.
Now taking that further, if you omit, if you're not aware about what you've just said about the risk, about the risk of the procedure going wrong, or some facts according to the domains, and you omit to inform the patient about that, will that constitute informed consent? That's what Dr. Chetty wants to know.
Yeah, I think it's suboptimal. For example, if I omitted, I'm going to operate the patient, I do an appendix, I remove this patient's appendix. I omitted to tell the patient that there's risk of death, and the patient dies. Now, the family can turn around and say, yes, you mentioned complication, but you never mentioned death. So this informed consent was suboptimal. Because if you had told us that our relatives can die, we would have said no.
Okay.
Yeah, so then it becomes a problem. But if nothing happens, you didn't tell the patient, there may be no consequences. The problem if that complication occurs, then it becomes a problem.
Okay, but if hypothetically you didn't know about the risks and you didn't inform the patient and that risk happens, what is the situation?
But then the problem is, I think as a surgeon, then there's something that's not correct then, because how do you do a procedure without knowing the risks? Because any procedure, is part of training, really. Any procedure, you should be able to know the risks and the benefits.
Yeah, okay.
Otherwise, then you shouldn't be doing that procedure if you don't know the benefits and the risks.
Yeah. Now the next question from Dr. Lebohang Mshe. I hope, my question is to Prof. Koto, is there a concept called post-operative consent? Briefly, pre-op consent with the patient covers only minor procedures. Intra-op complications result in major surgical intervention. Can this approach stand in court? But is there anything called a post-operative consent?
Now, I think for the operations, obviously, if it's a dire emergency, for example, patient comes, is stabbed, is shocked, you can't give consent. Here you would obviously we have to notify the superintendent, the CEO of the hospital, that this is the situation. Here is really touch and go to try save a patient who's in extremis. And then afterwards, then we can sit down. The patient is now alive. Then we can then counsel the patient that we had to take you in, and these are the problems, that potentially, even now going forward, these are potential problems. But we had to take you in because you couldn't not in a state to give consent. But remember, the consent is not only for the operation, but the consent of other things. For example, you must get consent to give blood transfusion. You must be able to get, because it is an intervention. It was potential for complication. The patient can have major reaction, including death. If you are going to do a lumbar puncture, it's got potential complication in lumbar puncture. If I'm going to place a central line, I need to consent the patient because potential complications may occur.
What about an ordinary IV line? As one doctor was asking that question. Should you always be getting informed consent for putting in just an ordinary IV line? Absolutely.
It sounds pedantic. It sounds, because there has been major complications from IV line, necrosis of the hand, necrotizing fasciitis. Actually, there's a case right now as we speak where they are suing the MEC of Health because the drip went into the tissues. They said the staff was negligent. So I think that also needs to be, if I'm going to put a drip, I'm going to put a drip, but this drip can do the following to you. Again, you need to record it. It's really an administrative burden. But, unfortunately today with the litigation that is all around us, is something that needs to be considered. Yeah.
So it's something that we should always be doing proactively, be aware of what may happen.
Absolutely.
We operate with that in mind. And how long, Nomongana wants to know, how long is an informed consent valid? If there's such a thing called that, it's
yeah, I think the key is it valid? Is it a valid informed consent? In other words, the patient understands. As long as the patient understands, my take is that it really doesn't really have an end, and unless now the condition of the patient changes. Suddenly now is no longer mentally capable, is now obtunded. That's a different discussion. But if the patient's mental function remains, there's nothing that makes the decision suspect. It shouldn't end. If I sign the consent, I'm not aware. Let me say I'm not aware of any prescription that it prescribes after a certain time interval. I'm not aware of that. As long as the patient is compass mentis, is able, understands what's going on and so forth, that consent should be valid.
Yeah. What about every consultation? That's what Medicuna wants to know. Patient coming to see you, consulting your rooms. is there a requirement to always sign an informed consent with every consultation?
Not every consultation. I think obviously the patient comes, there's no procedure or intervention. The patient comes in and then we discuss, what is wrong with the patient. But if the patient is going to go for surgery or a procedure, in the room, that is where the informed consent should be signed. It should be signed in the room so that the patient can sign, you countersign, and then the administrative thing that gets done in the hospital is really, that one is an indication that the patient has consented. It's not something that we should be calling consent, even though in theater, did he sign consent? But it should be done in the rooms. In other words, as the patient comes, I'm booking him for hemorrhoids. So I'm going to go through the 11 domains and then make sure the patient understands, and then they sign and countersign. That remains in my file. And then there's an administrative document that the hospital wants, but it basically follows the discussion we've had in the rooms with the patient.
Okay. So that document that stays in the rooms of the doctor, when the patient goes for surgery, goes into the hospital, shouldn't that copy also be in the file of the patient as an inpatient?
Yeah, I think that would be a great thing. That would be great, because remember, issue of informed consent, if this litigation is not a hospital that, gets, litigated against, is the doctor. But if there's understanding between the doctors that admit in a certain hospital, that copy should also be in the file. It's also, I think it's a good practice. It's a good practice that, it is also in the file, what we discuss with the patient. But litigation often won't go to the hospital, but will go to the doctor. Did you discuss informed consent?
Okay, that is in the case of a private practice, because in the public sector, there's what is called vicarious liability.
That's right.
In most cases, they would sue the MEC, the CEO of the hospital, and even the minister.
Absolutely. Yeah, that one in the hospital, it must be in the file, yes.
Yes. And patient's partner question. I'll come to you, Dr. Philly Masop, I'll come to you in a minute. It says, good evening, Prof. How many consent forms does a patient sign if he or she is coming in for 2 different surgical procedures that are performed by 2 different surgical teams? I assume this is happening at the same time.
No, then every doctor who's going to operate the patient has got a duty to obtain informed consent. So if, for example, I'm coming as a surgeon, I'm going to remove a lipoma, I must, on my own, without the other doctor, explain to the patient, go through the 11 domains, the patient signs, countersign, and then the common complications, everything that's covered in the 11 domains of informed consent are covered by myself. The one who's going to operate, if he's going to have an orthopedic procedure at the same time, the orthopedic surgeon also must go through the 11 domains and cover that. If he's also going to see, let's say, a urologist, the 3rd procedure, the urologist must also go through the same thing on his procedure, and cover the 11 domains, So each procedure will be judged on its individual merit, depending on who's. But if it's going to be, for example, let's say I'm one surgeon, I'm doing 2 procedures. Again, each of those procedures, I will explain the common complication, go through 11 domains, and then I will then combine the 2 procedures. So you will have in my file, there will be 2 areas of informed consent. I did a thyroidectomy. I also removed ingrown toenail. I explained the common complication of ingrown toenail. I explained the alternatives for ingrown toenail. I explained, the non-operative management option of ingrown toenail. Same with the thyroid. So that is in the file again. Because the complication, for example, may occur on the ingrown. So you took informed consent on the thyroid, but what about the ingrown toenail? Did you explain to the patient that the patient may end up with a problem with the toes? Yeah.
Sure, we're running out of time. I didn't think that we'd have so many questions. It shows that it's either an important topic. There are lots of questions. We're left with 1 minute. Maybe we can just extend it by another 5 minutes if it's okay with you, Prof. Koto, and the colleagues who are logged in. Philly, can you go ahead with your question?
Thank you very much, Dr. Bila. And Prof. Koto, it's not a question, it's a comment. My conscience doesn't allow me to keep quiet. Prof, you have done very well. You have done very well. And I'm your student from 1994 to 2006 as a medical officer under your wing in Sebokeng, Kopano. You've done very well. We are very impressed. And I really don't have a comment or a question, but I want to say one. After Chris Barnard did the heart transplant, there's never been any comment anywhere. And you are doing this work on the laparoscopic work. There's also work that has been done by Professor Chifilago on the ears and so on. And we are not saying anything on these matters. And we really want to appreciate the fact that you guys are doing massive work. We appreciate this thing. And my issue here is to say, keep on going and keep the institution on the map. That's what I wanted to say. And there's not much really I want to say. I don't want to ask you any question. I've been your student, from as a medical officer or an intern up to a principal medical officer in Sebokeng Kopanong Complex. I think I'm very impressed with the work we are doing. And I think this needs to be noted. We need to note, guys, I know that there are 300 people on this call. We need to note what these gentlemen are doing. Prof. Koto, Prof. Filaro, and others. We need to really note what they're doing for healthcare in South Africa. And I really want to support and say, keep on going well. I call it Medunsa anyway. I know that maybe the new name is Sepakomahatu, but I want to say, please continue doing the good work we are doing. Prof, we can't ignore the fact that there's 100% output of surgeons in your department. And I think this is notable. I'll end there, Dr. Bila.
Thanks a lot.
I don't want to be too emotional. Yeah. Thank you.
Yeah, you're making us have tears in our eyes. But I think what we do as Clinics Health Group is to acknowledge this distinguished clinicians and academics within our Black society and give them the platform to come and talk to us. And we just want to applaud Prof. Koto, and we had wonder Prof. Chifula was on this webinar just about maybe 2 months ago, and we had one of the other distinguished academics and clinicians, Professor Shisana Baloi last week. And so we'll use this platform to profile these excellent clinicians that we have in our midst. I'm going to take this last one question because it's not covered in the other questions from Neo Mongala. The hospital superintendent can sign during emergencies, as you mentioned, Prof. Koto. But what happens in situations where there are no managers, or clinical managers, I suppose, not even a medical practitioner?
Yeah, I think that's a challenge. First, let me thank Dr. Masupa. Philly, thank you very much for the kind comments. Yeah, I think that's a very difficult one, Dr. Bila. Obviously, if the clinical manager, I think the key here, the life of the patient takes precedence. I think, where the patient's life is in danger, a senior member of the surgical team will take that decision and say, here is a decision that's defendable, because really it's really a question of prioritizing the life of the patient over other administrative issues. We can always discuss that afterwards, once the patient is settled. So where there is no, it's a procedure that cannot wait, so the senior member of the team, whether it be a doctor or a nursing manager or a matron, will have to take the decision, but it's a very unusual decision. Often the superintendent, there's always a superintendent on call, and so we're able to get that. But if a senior person is absent. So a senior member of the team will have to take that decision, yes.
Thanks a lot, Prof. Koto. We've run out of time, basically. But I'll just read this one from Dr. Freddy Khongwana, which is the closing remark from my side, maybe. Because it says, can we encourage doctors to also sign and have a stamp to mitigate the unidentifiable signature? I think what it says that, because, we wish doctors don't write so legibly. So have a stamp also with your name, full details, and qualifications. You would agree with that, Prof. Koto?
Absolutely, yeah, I absolutely agree, yeah. Thanks.
Yeah, I'm very sorry, colleagues, that I'm not able to, for those that I'm not able to read their questions, they are on the chat line. I hope maybe Prof. Koto is able to see them. If we had a way of capturing them, would ask you to respond to them. And then we can then share the responses. But we don't want to keep people for a longer period. But what's left for me is to thank you a lot, Prof. Koto, for availing yourself and out of your busy schedule to come and share these thoughts with us and giving us a well-detailed and well-thought presentation and providing new insights about informed consent in our current way of practicing medicine. So just on behalf of Phoenix Health Group, I just want to say thank you very much for the time that you spent with us this evening. And also to thank all the colleagues who have joined us this evening. It is quite always a pleasure to serve you and to come here and bring speakers like Prof. Koto and others who have shared this platform. And the fact that you're coming in large numbers tonight, we reached a new high. I think we haven't seen this in a few months. I thought last week it was a new high, but today you've surpassed it, Prof. Koto, that we almost reached 350 participants. And so please continue joining us every week as we bring you these webinars. Next week, we're moving a little bit, changing gear slightly. We're looking at also an ethical question, but looking at private practice and also I think in the light of the health market inquiry, to say there are some inefficiencies identified with private practice, and also to say, we've got to, South Africa's got, it's a two-pronged country. We've got both public and the private sector is trying to meet the needs of the public also by providing private health medicine. But we've got someone who's going to be speaking to us about private healthcare and the moral challenge we faced in providing this healthcare as those practitioners in private health industry. And also just want to thank, we want you to encourage others to join us next week as we bring you quite a speaker, Dr. Aslam Dasu, who will be joining us next Thursday. And also to thank Phoenix Health Group for making this platform available so that we can engage colleagues and become a thought leader in medical education. And also thank the marketing team that is with us every week. Tonight we've got Zuki, who's been helping us with setting up these presentations. I just want to thank all of you and have a good evening.
Thank you, Dr. Pila.
Thanks a lot. Oh, Prof, you are going to come here as the HPCSA representative to talk about all the issues that have been raised. He will talk to you about it.
Thank you.
We must have a conversation.
There are too many.
There are too many. But then we'll give you 2 hours.
Yeah, but thank you. I will do that.
Yeah. Okay, sure.
I'll bring in a team. I'll bring a team.
Okay, sure. We've got a date.
Thank you.
Sure. Thank you very much. Good evening, colleagues.